This is the Louisiana Hometown Network, bringing you public information, coverage of the monthly meeting of the Louisiana Board of Regents for Higher Education and the Board of Elementary and Secondary Education, also known as BESE.
We have been asked by the National Association to lead the country in a series of dialogues around the cost and quality of health care. So we are here today as the first step in a tour across the nation to address this critical issue.
About half of the people in Louisiana live with some form of chronic disease, certainly in the adult population, and they account for 60 to 70% of all the health care costs. In Louisiana, we suffer some of the worst outcomes related to the impacts of chronic diseases. So I think for Blue Cross, the opportunity to invest in a program like Quality Blue Primary Care, to put new resources and tools at the hands of our providers to allow them to better understand who these patients are and help them take care of them better, offers a tremendous opportunity for not only Blue Cross, but for the people of Louisiana.
Across America, we spend 18% of the GDP on health care. Here in Louisiana, roughly 40% of the average household income is spent on health care. And we think that it's time for us to make some significant changes in the cost of health care without sacrificing quality.
Appreciate the opportunity to be here with you this morning, and I do thank you for your time and attention in joining us on this journey. We don't want any passengers on this journey. We need active participants on this journey. So I beg of you, engage. That's what we need. The time for engagement is now. I can't thank our association enough for the opportunity to start this nationwide series of dialogue here in Louisiana. In Louisiana, where we're always bouncing off the bottom between 49th and 50th in total outcomes, which is basically the health of the population. Come on. We can do better than that. The average household income in Louisiana, we spend 40% of the average household income in Louisiana on health care. So we spend and we're not getting the outcomes. I remember I'm 30 plus years, I hate to admit, with Blue Cross. I know, 10's more appropriate, right? I'm the old dinosaur. And I went to our organization, the senior team, and said, you know, this GDP, we're spending 17% of GDP, moving to 18% of GDP, and moving to 19% of GDP, 20% of GDP. I said, we got to stop this. And I didn't mean by stopping just it taking longer to get from 18 to 19 than it did from 17 to 18. I'm talking about stopping it at 18 and reversing it down to 17, 16, 15. And they all thought it was crazy. And maybe I am. And we can't do it alone. This is an American issue, and we're going to tackle it in one of two ways. The first way is 72% of disease is preventable. So can we reverse the course of the cost of health care by just addressing the things that we can make small behavioral changes in our lives in order to reduce health care costs? Yes, we can. 72% of disease is lifestyle related. It's avoidable. We're not going to eliminate it all, but let's acknowledge it. And let's find ways for us to look inside of ourselves when we wake up in the morning and find ways to address health care costs. The other thing that we can do, and the other thing that Blue Cross and Blue Shield of Louisiana is doing, is spending tens of millions of dollars a year in providing data and information so that for the first time, we can begin to build a healthcare system. What we have right now is a healthcare model. A system would imply that there's a brain, someone there trying to coordinate all the activities. It's pretty much a siloed activity in healthcare today. So we want to take the data and the information and make it actionable, be able to share information with our members so that they understand their healthcare risks, be able to take and share information with our provider partners so they have a better view of their patients. They understand the total patient. It creates the system of care that can begin to address some of the waste and inefficiencies in healthcare today. So the time for change is now. It's very clear. And we have the greatest healthcare in the world, and our challenge and our opportunity is to make sure that we retain that bragging right of Americans having the greatest health care in the world. But we can't do it if we continue to stick our head in the sand and not address the things that are really plaguing America. That's the cost of care. Keep our eye on quality, do not sacrifice quality, but look to address the things that can begin to bring down cost. So I thank you for being here. I very much appreciate your devotion to this, and we look forward to a very engaging day. So it's my opportunity at this point to introduce our Senior Executive Vice President of External Affairs, who also doubles and triples up as our Chief Medical Officer, Dr. David Carmouche. Dr. Carmouche will provide some additional color before we get started this morning. Thank you, David.
Thanks, Mike. Good morning. Let me add my welcome to all of you, and thank you for being here today. You know, before I came to Blue Cross 2 years ago, a little over 2 years ago now, I was in practice for 15 years in Louisiana, here in Baton Rouge. And I led some quality improvement projects both in my practice and across the state. And when Mike asked me to come take on a greater responsibility here at the health plan, you know, the question I had is on the screen. Can a health plan, can a payer really drive healthcare quality improvement? You know, I had my doubts, in all honesty. As a provider, payers got in my way of providing quality care. They were a barrier. They extracted more from me than they gave, and our relationship was adversarial frequently. I'd like to think that we're starting to change it. And today we're sharing some information with you that we've never shared before publicly, and that is that the cost of health care, at least for Blue Cross members, varies tremendously, almost twofold difference in a risk-adjusted per member per month cost based on the parish you live in the state of Louisiana. So again, think about that. For the same risk, depending on where you live, your health care can cost somewhere between $330 a month and $540 a month. Now, what's up with that? You'll hear later today, I'm sure, from Elliott that we now know that spending more on health care does not equate to getting better health outcomes. In fact, frequently the best outcomes in the United States are delivered within systems that do it the most affordably. On the right side of this slide is just one piece of information that we can start to share. This is information on total knee replacements. Per 1,000, depending on the parish you live in, 10-fold difference in the rate of knee replacements. So healthcare is being delivered disproportionately in terms of volume and the cost of those services. And when you start to dig into it, you can start to see, here's a slide that just shows emergency room utilization. You can see on the screen the size of the dot, the larger the dot, the more emergency room visits per 1,000, the smaller, the fewer. The orange slice is avoidable ER utilization. And what you rapidly see is that in every parish in Louisiana, most of the emergency room utilization is avoidable. What's avoidable? Meaning the diagnosis code for the visit suggests a condition that either could have been managed appropriately in a primary care office or in a less acute setting, or is a complication of a condition that, if well managed, would never drive someone to the emergency room. Low blood sugar for someone with diabetes, for example. A hypertensive emergency for someone with high blood pressure. So we know ER utilization is a significant opportunity in the state, and it's a real big opportunity in some parishes versus others. The next slide is data we have on inpatient admissions per 1,000. Again, the bigger the bubble, the bigger the number of admissions. Huge disparities. In most of the urban areas in Louisiana, actually, avoidable inpatient admissions are quite low. In the rural parishes, it's an enormous problem. Of those admissions, there's a significant number of them that are avoidable. Again, with better care, these people would never need to be in the hospital. When you put dollars to those opportunities, it's tens of millions, probably hundreds of millions of dollars just in this state alone. And so we know that there's a huge opportunity, and our data starts to point us to where that opportunity exists. Now, as a clinician who really spent most of his life treating cardiovascular disease and preventing heart attack and stroke, This piece of information from the CDC is really what got me agitated in practice and what keeps driving me now. If you look at mortality rates by parish or by county across the United States from heart disease and stroke, the Southeast is riddled disproportionately with these conditions, and Louisiana is in the center of the bullseye. This is not good because this represents family members, this represents neighbors, this represents children and parents who are not living a full life because of conditions that are absolutely manageable, and we're not getting it done, frankly. So this was really the mission behind a program that we launched a year ago, because we believe that primary care is a large part of the answer. If we could get most of our patients, most of our members, hooked into very reasonable and high quality primary care and share information with those primary care doctors to point them to the opportunity and reward them when they take good care of them, that we would be changing healthcare in Louisiana. And so we designed a program called Quality Blue Primary Care, and it involves a lot of pieces. It involves a major commitment in infrastructure. We purchased access for all of these providers across the state to an information technology tool that allows us to connect to their electronic medical record and feed a database with information from our claims system and from our pharmacy data to provide a registry to allow our providers for the first time to see all of their Blue Cross members and to understand the risk of those members and to segment them by that risk and to allow them to be aware of the people who aren't in their office that day. We changed our payment model. Instead of just paying for the number of services these providers gave, we started to attach a monthly payment to patients who have chronic diseases, realizing that the care of these types of patients requires more work, it requires telephone calls, it requires a coordination, it requires things that today providers can't bill for, and we wanted to create a payment model to support this work. And importantly, we wanted this payment model to be richer when outcomes were better. And we wanted it to not be so rich when outcomes were poor. And we were going to share data across the state and really point out practices who were doing this work well so that those who weren't would have someone they could go talk to. I'll tell you how that's played out in just a minute. Third thing we did was we provided education as part of this program. All physicians in the state need continuing medical education, and increasingly it's hard to find good quality CME. So we built in a CME component to this program that allows physicians to really learn about how to manage some of these conditions, how to change processes of care. The fourth thing we did was we leveraged 120 nurses that sit in the walls of Blue Cross who are care managers, disease coaches. And we said, God, these people are sitting in the walls and they're doing great work, but they're not connected to the primary care doctors. How do we connect them? How do we make sure that the nurses and the doctors in the trenches understand what we're doing, and how do we help them in a more coordinated way? And so we've integrated our care management now virtually into these practices. So Quality Blue Primary Care has been up and running for a year, and this is the footprint. 450 primary care doctors across the state, from Shreveport to Lake Charles, down to New Orleans, Baton Rouge, all over the state, caring for 137,000 of our members today, attributed members, people that actually have a relationship with these providers. 51,000 of those people have a chronic disease, hypertension or diabetes or chronic kidney disease or vascular disease. And we've paid out in the first year over $2.5 million in care management fees, these new payments that I mentioned before. So the program has gotten very big very quickly. And the reason it has is because providers believe in this. They say this is a way for a health plan to tangibly invest in the healthcare of our state, and we want to be part of it. And so we're very gratified with the adoption. We haven't forced this program on anybody. And most importantly, this program is driving behaviors. If you look at this graph, the colored bars, each of the colored bars is a month. It's the first 6 months of the year. Compared to a group of people who aren't in this program, members, you're like twice to 3 times as likely to have seen your primary care doctor if you're in our program. So the outreach to get people into the doctor, where the magic of the physician-patient interface occurs, has been very successful in this program. And then outcomes. This program doesn't matter if we don't start to move the needle. So this is the first year's data. Diabetes care has improved 12% in the state. Diabetes care meaning blood sugar control and blood pressure control and cholesterol control and non-smoking status in an individual patient. All four have to be present to get credit for that. That metric for improvement has gone up 12% in the first year across a large number of patients. Hypertension care, meaning just are we controlling blood pressure or not? Now that we're connected to all these electronic medical records, it's either yes or no. 28% improvement in blood pressure control rates in the first year of the program. Vascular disease care, are people not smoking? Are they taking aspirin? Are they on a cholesterol-lowering drug? Is their blood pressure controlled? All of those things present, 32% improvement. And finally, you know, we're in a state where we have a lot of chronic kidney disease and a lot of people move on to dialysis every year. A lot of Blue Cross members move on to dialysis every year. So optimal management of these people includes things like tightly controlling their blood pressure and using specific drugs that have been shown to retard the progression of kidney disease, 69% improvement across the state. So I'll end by just saying, you know, the most gratifying thing from this program is that last week we held an event here in Baton Rouge where we invited a member of each of these practices and their administrators and their nursing personnel to come to Louisiana for what we called our first Quality Blue Primary Care Stakeholder Summit. And what we did was we celebrated the first year. We had folks from our association, our Chief Medical Officer from the association, Trent Haywood, just really validating what we were doing in Louisiana. We awarded practices for their achievement. We had a practice in Shreveport called the Family Docs that won 3 awards. We had a group at East Jefferson down in the New Orleans area that won an award for chronic disease care. And we had a group here in Baton Rouge, the Baton Rouge Clinic, which frankly, and in some ways I'm proud to say was my former group, won the award for best overall performance. But what was really great about that event, and you're seeing some images on the screen from that event, was the excitement in the room. Providers from Shreveport were talking to providers from New Orleans. Nurses from practices were talking to care management people from Blue Cross. The buzz in the room was that we were doing something very special. And so I think the answer to my question is yes, a health plan can drive quality improvement. I hope to be able to report out in the future that all of this quality improvement equates to healthcare cost savings. I believe it will, and we'll have the data to be able to show that. So again, welcome for those of you who've come in from out of town. It's an exciting day for Blue Cross of Louisiana. It's an exciting day for our association, and let's have a great meeting today. Thank you very much.
When you see such substantial changes from what we just heard from Dave about Blue Cross Blue Shield, to me that says there's something going on that's fairly dramatic, that there's a killer app, that there's a sort of a different thing. And so before we get into Million Hearts, I'm just interested in whether, as you look out at the broad American healthcare scene, is it so dismal that you can actually get strategic leaps like that in a variety of places?
It's not dismal. In fact, it's the most exciting time ever, I think, in cardiovascular disease, because we are seeing pockets of high performance. What's happened in Blue Cross Blue Shield in Louisiana is extraordinary, but it is not unique. In Million Hearts so far, we've seen
So you're seeing the similar things in other places?
Absolutely. And beginning to distill from those high performers the lessons, the essentials for success, and trying to disseminate those lessons quickly so it's not 19 years between understanding what the evidence says and implementing.
So what do we know today that we didn't do 5 years ago that is helping to make this happen? I mean, I think that you have to ask when you see such substantial change, and I agree with Mike that, you know, I used to work in the United States Senate for a senator from New Mexico, and New Mexico also was an economy very low on the list in terms of comparison to other states, very, very low health outcomes. And I remember on the economic side of the equation how hard it was to get from 48th in the country to 47th. But when you see, you know, big shifts in sort of health realities in Louisiana, what do you think we know today that we didn't know 5 years ago?
You know, I think it's a crossroads, an intersection of the availability of data and data that you can trust, and then the impact on your personal life, your family, and a sense of outrage that it's time to change. So overlaying the data and that outrage is what exactly can I do? What one step can I take? And we're getting clearer on those steps.
And tell me about Million Hearts.
Million Hearts is a national initiative, and we are very proud to have Blue Cross Blue Shield Louisiana as a partner. It is to prevent 1 million heart attacks and strokes by 2017. So it's a 5-year full-on sprint to try to prevent heart attacks and strokes. And we're doing it based on the data, based on predictive models that have told us how we can actually get to that 1 million prevented events. Two-pronged approach. One set of actions are public health actions at the population level. So trying to eliminate trans fat from the food supply, something you don't really need, you won't miss it when it's gone. Gradually lowering the sodium intake for all of us, and increasing our exposure to smoke-free air. So all of those things are policies and at the population level. But on the healthcare side of the Million Hearts family, the goal is to get excellence in what we call ABCS. Just as David mentioned, it's aspirin for those of us who need it, blood pressure control, cholesterol management, and the S is for smoking cessation. Because we know when we get excellent in the ABCS, heart attack and stroke rate falls like a rock.
So, I mean, I love this. I mean, I'd love to sort of talk to my bosses about all of the heart attacks I have prevented for a year. How do you prove the negative?
Right, so you actually count. So you count how many occurred in the country before the launch, and you count how many occurred after the interventions. But Million Hearts is not interested in attribution. The work is actually done by organizations, by groups, by...
So you inspire them and bring them along in
and not just inspire or motivate, but actually hand to them the strategies that work. Because we know in cardiovascular disease how to prevent heart attack and stroke. Most of them, as Mike said, are preventable. And so it's getting out those actions that you can take so you don't waste your time and resources on things that won't help. You only do those things with an evidence base.
You know, I am interested in this, you know, the issue of feedback so that we can understand and potentially change our behavior. So how does that fit into Million Hearts, and how are you working with the private sector, and what behaviors are you seeing? Because I know a lot of friends who are not diligent about this, but I'm interested in how you see the phenomenon.
So a great example is blood pressure. Let's talk about blood pressure control. Why are we in such a mess? Right now, 1 in 3 of us has high blood pressure in this country. And the control rate, the chances that we're under control, is a coin flip. 50-50 chance outside of Blue Cross Blue Shield Louisiana. So why is that? Well, we're using a model for blood pressure control that takes you, Letitia Presley Cantrell, my colleague from CDC, brings her into a doctor's office and measures blood pressure once, maybe twice. And then the healthcare professionals and Letitia try to make a decision about treatment or even diagnosis based on 1 or 2 data points in an abnormal setting, when we all know that Letitia's blood pressure is not the same in that office as it is at home, in the gym, at church, at work. Certainly not at work. So we want to empower people to be their own blood pressure managers. Think about it. We ask folks who have diabetes to stick themselves with a needle, check their blood sugars, decide how much of a drug they use that if they overtreat or undertreat have serious consequences, and often for insulin-dependent diabetics inject themselves. And yet we don't teach people how to manage their own blood pressure. So devices and technology can actually help with this. Devices that we can wear or blood pressures that we can use and monitor at home, sending those pressures back to the treating provider, making sure that we get timely advice back to the individual. Creating that new loop and that self-management will actually help bring blood pressures down. I think the Navigator program at Blue Cross Blue Shield is a human equivalent of that.
Can you leapfrog over, you know, some of what we see as the incumbent interest problems in the modern, in our healthcare system today?
Right. I think what I go back to is what I have learned from the high performers. And physicians and nurse practitioners and pharmacists and PAs and community health workers, they are not marginalized in the high performing networks. They are actually a fundamental part, but they're not obstacles. They are no longer the stenosis, if you will, in the healthcare system because of team-based models where individuals are getting care from folks that they trust, from often people in their community, and the clinical and community linkages are tight.
What I also understand about Million Hearts is you tend to focus on communities that one might call the left behind communities, the communities that are are either for race or socioeconomic disparities, hard to reach or whatnot. And I'm wondering how do you look at them, say, you know, as a difference between the greater DC community or greater New York community? What sorts of methodologies do you need to put in place to reach some of these highly impacted communities in, say, New Orleans?
Right. So what we learned is that where results are being, where improvements are occurring, they're occurring from the ground up. So they are occurring from organizations that live in a community. That might be a church, it might be a barbershop, it might be a library. There are other places where people congregate, and having individuals there who have a knowledge base and a skill set to train, it occurs this sort of empowerment that we are seeing. And then we start to see improvements.
Can you give us a case? Can you tell us a story?
So one great case, and this is just from last week, Arkansas, where I grew up, and we are always in competition, Mississippi, Arkansas, Louisiana, for the bottom.
For the bottom.
For the bottom. Yes, but those things are changing, and here's a story. There's an organization, a quality improvement organization in Arkansas that has done awesome work in providing education, training, skill development, and awareness around the use of data in the state of Arkansas. So they have reached out to the national parks for walking programs, to libraries where people can access data and also have group trainings, to a lot of the healthcare professionals in the state, and also churches. Cities have declared heart health weeks and heart health months and proclamations. So there is an upswelling from the population there to focus on A, B, C, and S.
I mean, who's getting it most right? I mean, was impressed with that ice bucket challenge with ALS. My mother in Bartlesville, Oklahoma, was involved with a lot of the cancer survivor activities that went on, and a lot of them became very fun, constructive, positive. Are we getting the kind of, I just love when Mike came up here because he was so positive, and I'm so used to healthcare forums being so dreadful and negative and down. But I mean, is there something about the provision of healthcare and getting people to become stakeholders in their own health where we haven't found, where we maybe ought to be talking about social media apps or different ways to reach people than just I don't know, the aspirin approach?
Right, right.
I mean, maybe you want them to take aspirin, but getting them to understand the importance of it, you know, they could see it, I don't know, potentially on, I don't know, Homeland as a smart strategy. Are there elements of this that you consider that are kind of avant-garde marketing opportunities?
Yeah, I think the availability, I think where we're making the most headway and where we're learning the most is in blood pressure control, with individuals actually becoming their own best managers. So I am excited about the convergence of technology and new processes of care and knowledge there.
And tell us about blood pressure. I mean, if you were going to change my blood pressure behavior, what would I do?
So I'd ask you what your blood pressure was this morning.
I have no idea. Is there a way I can get an app right away?
Yeah.
Do I have to put one of these little things on me?
You do, but there are technologies available now that the monitor that you put on, you can allow your blood pressure readings to go directly into your electronic health record in your healthcare provider's office. The great thing about that is that provider starts to look at a whole pattern of blood pressures instead of a single reading, and should be getting back to you really quickly about some advice.
And is there a way, once you begin to inform me through this novel technique of what my blood pressure is, what I ought to then do?
Absolutely.
Is it going to say go see your doctor? I mean,
absolutely.
I would do all this stuff if I didn't have to go see my doctor.
Exactly,
right,
exactly. And the steps that you need to take are actually not steps that you have to take through your doctor. So apps that allow you to say, well, if I cut down my sodium by X%, fewer teaspoons a day, or it's mostly restaurant and processed foods that add your sodium to your diet, it can actually show you how much that will bring down your blood pressure, or what the extra 5 miles would do, or 2 miles a day might do. I want everyone to know it is within their power to prevent heart attacks and strokes.
What are the simple steps for people?
Each individual can make healthy choices each day, and then each healthcare professional can get great at what we call the ABCS. That's aspirin, blood pressure control, cholesterol management, and smoking cessation.
So you heard the conversation, some of you, that we were having before, and I think part of what we're here today is to sort of look at if you had an opportunity to really sculpt a very different, much more healthier health system, what would that look like? I've been reading a little bit about Peter. I just love this notion you have, sitting kills us. But tell us a little bit about sitting killing us.
Well, yeah, over the last decade, I guess, we have several studies coming out showing that the more time we spend sitting, like we're all doing right now, the greater your chance of developing heart disease, type 2 diabetes, and dying prematurely. So, you know, when we're all sitting, we've totally deactivated our lower limbs. And we all know that this is the largest muscle mass of the body and is very involved in metabolism. So when you deactivate that much of your body, I mean, it's devastating.
It's a serious issue.
Yeah.
Warner, you've just come down, as I understand it, from New Hampshire.
16 years ago.
Oh, 16 years ago. Okay. Well, I had some. Apparently, my people gave me some data points. I thought it was 2 years ago. Well, glad you've been there. So you didn't want people to know he's from New Hampshire. In any case, I am interested in this broader question. You run a big healthcare system. You've got 8 hospitals. Maybe it's 20 now, from what I had in my report here. But there is this thing that many people have looked at about very big differences in the north between the south, and I'm interested in just your experience in a place like New Hampshire.
Sure.
What were the characteristics? What were the behavioral issues? And then what were the structural features of a well-performing healthcare system up there versus how you get it right down here in New Orleans or down in Louisiana?
So, there's a lot of differences, obviously, between New Hampshire and New Orleans. I mean, they both have new in them, but other than that, there's a lot of differences. But I would say the fundamental construct of the health systems are not significantly different. I would say the idea around wellness and activity, probably there are some differences there. But as we heard earlier, the whole focus around the management of chronic disease, which really drives about 70% of the healthcare cost, is no different in New Hampshire or Vermont than it is in Louisiana. My mom's 86. I actually talk to her every day. She has chronic heart disease. She's been in and out of the hospital for the last several months. And the management of her chronic heart disease isn't any better in Vermont than it is here. So I think one of the fundamental issues we have in the healthcare system is the management of chronic disease.
Right.
And we talk about centers of excellence around cancer, and we talk about heart attacks and stroke, which is incredibly important, but we got to talk about obesity. We've got to talk about mental health.
And these chronic disease factors are huge in Louisiana.
Exactly. Yeah. I mean, and they're huge in our country. It's not just Louisiana, but they're huge in our country. Right. And once again, I would say Louisiana is no different there than a lot. We may have a higher prevalence, but we certainly have the capability to manage chronic disease. But I would say generally the healthcare system has not been good at managing chronic disease, really probably in many places in the country.
I want to encourage everybody to kind of finish each other's sentences. Don't wait for me to necessarily come in. But I am interested in this issue of if you were made all-powerful, if you were given a magic wand to change things dramatically, what would be the 2 or 3 things you would most shift, given your experience in this profession, to get radically different profile when it came to these chronic diseases?
To me, it comes back to the payment system as part of it. And I would just say actually generally the incentive.
So payments, fee for service?
Fee for service versus some sort of global payment and the total cost of care. I mean, that's part of it. But let's start with personal responsibility first. We obviously are a large healthcare provider, but we're the largest private employer in Louisiana as well. So we employ 16,000 people. Mm-hmm. So we really have, we look at 2 sides of the equation in providing the health care, but also being an employer. We spend $70 million a year in benefit costs. So, several years ago, we took an approach with our employees to say, look, if you're in our wellness programs, your health insurance is going to be anywhere from a single person, $1,000 to $2,500 to $3,000 cheaper if you're in the wellness program. Now, it's pretty rigorous. It has a big component around activity, obviously having devices, so we know if people are being active. And what we found is in the last 4 years, our organization's lost over 100,000 pounds.
Wow.
We've seen an improvement in body mass index. We've seen improvement in the control of blood pressure. So that's had a big impact, and we see a difference in our
What's
total.
your conversion rate in terms of the percentage of your workforce participating?
So initially it was probably about 40%. It's probably closer to like 85% now. Now I'm not saying 85% earn the incentive,
right?
But we have 85% participating. We have, I think it's in excess of 40 or 50% now that actually earn the incentive. So it definitely has gotten the organization moving, and it has people taking more personal responsibility. We have a surcharge, or actually I guess a discount if you're a smoker. And we had a lot of feedback that you can't get into our personal business and whatnot from our employees. And we said, look, we're not in your personal business. It's just that if you choose to be more costly, if you choose other activities, you can't send the bill to your colleague. You need to pay more to do that. So it's been, it was a little controversial when it started, but it certainly has been very effective in engaging our workforce around wellness and engaging our workforce around personal responsibility.
Randy, how do you see the profile problems? And say you govern the insurance for a school board district, as I understand it, but you've looked at the insurance dimensions of that and the profile, and again, I keep hearing these great data points, and I just want to say, well, why isn't everybody doing that? Why isn't everybody doing the same thing? What are the practical problems with replicating what Warner just talked about, or what Peter's talking about, getting everybody up and just beginning to walk a bit?
Well, first, let me say, Warner, I'm from the north too. I'm from Shreveport. So.
There you go. The Shreveport crowd is watching now, and flags are high.
I spent most of my career in healthcare and a healthcare CEO, so I understand the challenges that providers have.
Right.
Providers, it takes so much money to run a system, and with Medicare and Medicaid cutting those costs, they're looking to third-party payers to make up and subsidize that. And that's putting more pressure on cost and premiums to our members. I'm an advocate. I think everyone needs coverage. I mean, it's ridiculous in this day and age to think that people don't have health insurance coverage, and they should have it. But the problem is that we're shifting these costs to plans that so far have been able to pay it, but the bottom is about to drop off. And with the Affordable Care Act, that is pigeonholed us into these are the minimum benefits, these are the maximum benefits, the fees and taxation is going to catalyze, to me, the dilemma that we're going to get in very soon. But to me, there's a much more basic thing that we need to address with our members. Our members call all the time, say, which doctor should I go to? Which hospital should I go to? Which ones cost more? Which ones have better quality? And if we're going to make demands of providers, we need on the other end of it, if we're going to make demands of providers and we're going to shift toward primary care, which I'm a big believer in, we have to shift resources into supporting those primary care providers.
So how do you do that? I mean, in Virginia, as I mentioned with the secretary interview, they are hiring a lot more. They don't have the federal support for Medicaid, but they're taking the money they're getting and throwing it into what this gentleman was talking to, navigators, mentors, folks that can help people doing. They're hiring gobs of them to help people
that's a good question. I think that I'm a believer that the industry needs to reform itself. The government is not going to reform us. And whereas the Affordable Care Act is trying to make the attempt to get everyone covered, it's not reforming health care from within. So I think that's what I'm so glad about this forum and for Mike Wright's putting this on so that we can sit down and we can look at partnering with one another. Unfortunately, carriers and providers, self-insured plans, we're so often we're adversarial. We're saying providers need more money to operate, and we're saying we're tapped out and we don't have any more. We have to look at this differently. We have to do it differently. And the first thing is we have to understand that we're all going down together. When the money runs out, the provider is going to have to cut costs and quality is going to get even poorer. We can't get there from here. We can't. The program that Dr. Carmouche came in with, I was very excited about. It was skeptical at first because fee-for-service rewards volume and traditional capitation rewards less service. So I think those traditional models have run their course. So providers...
You've just said something I think really profound and interesting. With what Dr. Carmouche shared this morning, were you a part of that program? Were you a part of that?
Yes, we
you were part of that.
Program.
And I hate to be crass about that, but what would be, you would say, the economic dollar volume of a fee-for-service world, say box A, versus box B, what you guys just experimented with, and you got these, you know, staggering results. But would the dollar volume of healthcare expense be greater, the same, or less?
Well, we think that it'll be less, but I think as employers, our responsibility is to be able to put ourselves at risk with the providers and say we're going to develop the reimbursement system. We are going to support the providers because the providers are going at risk too. And it's not fair to expect them to go totally at risk. And so we need to be able to make demands of the carriers and say we need the information systems, we need the reimbursement systems, we need the data systems, and then the employers need to sit back and support them and say what resources, whether that's financial resources or that's plan redesign. And also on the member end, the members need to be responsible too. A non-smoker paying, right now we charge the same premium for everybody, whether you're a healthy person or not healthy. Now, we can't always control our health, but the things that we can control, that person that takes care of themselves should have a lower premium or lower out-of-pocket than someone that doesn't. And so we need to be able to ante up, and that's what we're doing, and sit down with the carriers and providers, support the providers, support the carriers, because we're all in it together.
At the core of the Partnership for Achieving Total Health, or PATH, is the Greater New Orleans Health Information Exchange.
Right.
And so we connect over 50 physician practices with 2 of the major medical centers in the region, and help get information where it needs to be, when it needs to be there to inform clinical decision making. I'll give you an example of how that works. So these are unaffiliated practices, not affiliated to the hospitals or owned by the hospitals. So we're talking about multiple different medical record systems that are linked through this health information exchange. If a patient of one of the primary care providers in the network arrives at the hospital, an alert along with the clinical summary will be sent real time to their primary care provider so that their care managers can follow up on that admission and do what's necessary to prevent a readmission. So it's all about advancing population health, quality, and reducing costs. I'll tell you that for those patients who are in the health information exchange and have consented to have their information shared, they, when they are admitted to the hospital and get the alert sent to their primary care provider, they're 8.5 times more likely to get a follow-up appointment with the primary care provider in 7 days than those who aren't a part of the information sharing. So it's a very effective tool to utilize the data, make it actionable to improve the health outcomes of the population.
I'm really interested in the cost and quality issues of the population of Louisiana, especially where population health meets the healthcare delivery system. I'd like to explore that with my fellow panelists and get a better understanding of how we can work together to address not only the cost and quality issues within the healthcare delivery system, but addressing some of the social determinants of health that happen outside of the doctor's office.
Understanding the triggers of chronic disease is what we do at Pennington Biomedical every day. So the fact that this summit is looking at healthcare and healthcare reform and what we can do in Louisiana to really change things and make an impact, it's important to us.
First of all, I've worked on all aspects of healthcare, from the provider, the carrier side, and the employer, and the problems with healthcare, the market is not resolving these problems on its own. And I wanted to be part of this summit to be with my peers and other folks that are involved in healthcare so that we could identify our common problems and identify common goals so that we could start changing the model of delivering healthcare that will benefit both providers, the members, and the employers.
My message is that we really need to continue to change the incentives in healthcare. We need to make sure that we are putting the right incentives for the providers to focus on cost and quality, and also look at personal responsibility for folks for their own health and their own care. So I think that's an important message for everyone to hear.
So for almost 30 years at Dartmouth, we've been studying variations in per capita spending across the country and variations in quality. Early work showed that differences in per capita spending across the country are about 2.5-fold. That raised the wonderful question, so what do you get when you spend more in the context of American healthcare?
Louisiana spends a lot.
Well, Louisiana spends a lot more. So it does turn out that about half of those differences are due to differences in health status, but that leaves a huge amount that's due to the characteristics of the healthcare system. So, you know, when we did a whole bunch of studies that were a pain in the neck but ended up being pretty important, what we learned is that if you control for health status and look across health systems that differed radically in how much they put into people, the higher cost healthcare systems are not doing any more of the things that we know that work. They're not treating diabetes any better. They're not treating heart attacks any better. They don't do more elective stuff. You would think, gosh, you're spending 60% more per patient. You'd get a few hip replacements for it. You don't get any more of that. What you get is more time in the hospital, more time in post-acute care, more visits to specialists. And those higher cost systems, you're 3 times as likely to have 10 or more different docs involved in your care in a given interval. So care is incredibly fragmented. And then the studies also showed that outcomes are actually no better in those high cost systems. What this showed, and now there's 20 more years of work that I think shows it's correct, that we could probably reduce per capita spending by about 30% if we were able to mimic the high-performing healthcare systems in the United States that are predominantly primary care oriented, fewer specialists per capita, and patients spend less time in the hospital.
So can you go through some of those communities that you've had?
So
there are about 10,
LaCrosse,
you look like 10 of them.
La Crosse, Wisconsin, Rochester, Minnesota, where the Mayo Clinic is. There's some counterfactual places. Texas, Austin, just north of Austin, Texas, where Scott and White is. And the rest of Texas on our maps where red is high cost, Scott and White looks low. Temple, Texas looks low. And what it is...
So catch me up. Is Scott and White a hospital?
It's like Ochsner. It's an integrated delivery system, medical group practice.
And do they also pay their doctors' salaries?
They pay their doctors' salaries. They're not yet under the new payment models that we think are really important to make it possible to succeed under this world. But they do, the higher performing systems really look as though they're invested in primary care, and it's probably by chance. They've also figured out how to provide more integrated, coordinated care.
By chance?
They didn't build too many hospitals, right?
So there's a bricks and mortar problem in healthcare. There's a huge bricks and
mortar problem in healthcare. I mean, if you pay to produce health services, and hospitals have to balance their books by generating revenue rather than being rewarded for keeping people out of the hospital, they're going to build more beds. They're going to buy more of the devices that they can bill for that generate high revenues. So the question is, how can we change, how can we move to a payment system that rewards all the wonderful things we were just hearing about in the prior session? And that's been the fun challenge of the last 5 years.
What do you think the 2 or 3 things any community, we have right now at Shreveport and Lafayette, and I'm sure I'm going to forget somebody, New Orleans, and Monroe. What could any of these communities, what would be the 2 or 3 biggest things for them to sort of reflect on in terms of how they think about healthcare that they might be actually able to truly mimic some of these communities you've seen and move the needle when it came to their community healthcare?
Well, gosh.
I mean, because replicability is what matters.
Absolutely.
If you've just got a unique thing north of Austin, Texas, who cares if you can't do it somewhere else, right?
Replicability and spread is really important. So, the term ACOs was thrown around a little bit earlier.
I was throwing it because, and then he says there's not even a real definition to it.
Accountable care, well, they used to call them unicorns.
Where's our friend, the gentleman in the back, the accountable? We want to make sure you're in the room. Don't go away yet.
So
I know you're near the door.
We used to call them unicorns, right? Because no one had ever seen one.
Well, he made an interesting point that depending on where you sit, there are very different definitions of what an accountable care organization is, and you're looked at in the United States as one of the chief promulgators of accountable care organizations. So what is your definition? You're the oracle.
No, I'm not predicting the future. I'm trying to influence the future. Along with you guys.
What would you like an accountable care organization to be?
I think these are systems that are committed to improving the health of the population they serve, improving the quality of care at every stage of life, and lowering the total cost of care for their community. And they're doing it by working as hard as they can to move from current payment models to more capitated global payment models in whatever way they can with contracting. Unity Point Healthcare is one of the early ACOs, used to be called Iowa Health.
Iowa Health?
It used to be called Iowa, now it's Unity Point. Every healthcare system changes their name whenever they can, as far as I can tell. And so they decided they were going to become, there were 11 hospitals, they decided they'd become a health system, led by physicians but focused on patients. If I were leading a healthcare system here, I'd say I'm going to have a global contracting platform, just as they did, that said our job is to help all of our contracts move toward the global payment models we were talking about this morning. So starting toward pay for performance, shifting toward episode-based payment, and then shared savings is now possible under Medicare. It's not a great program. It could be much better. But try to get to a system that rewards you for keeping people healthy. So that's one thing. Payment reform is absolutely essential. We're not going to fix this until we fix the payment system. It just doesn't work.
So can we just pause there just for a nanosecond?
Sure.
Everybody talks about payments. Everybody says, what's the biggest impediment to just changing the payment system?
Are there any doctors in the room?
I mean, yeah.
Are there any hospitals in the room? Are there any policy legislators in the room? No, you're not here. You're off.
So is it a legislative issue? So, is it a just a business track? It's hard to get off the groove that you've dug in so deeply. I mean, I don't ask it facetiously. I'm not in this world, which is why I can ask naive questions, but it just seems to me that every person in this discussion, everywhere in the United States, and I get to travel a lot talking about healthcare, when I joined the Atlantic, I told them that the issue I like least is the healthcare discussion, because it seems like there's so many logical things that the healthcare system sort of stays far away from. But what are the real big barriers to just changing? Is it just inertia?
Change is really hard in complex systems. So especially, Clayton Christensen, who's an innovator, talks about this. The hardest things to change are big, entrenched organizations. All of their processes are set up to do things currently around how they're reimbursed under fee-for-service. So you imagine trying to change a hospital where everybody has grown up thinking their job is to make a margin, so they continue to have a positive margin and don't have to lose money. Physicians are trying to run their offices. So you've got changes that need to be made in how systems run. I think the changes in payment models are, can we get the payers, Aetna, Cigna, Blues, others, to agree that we should all be moving toward this new payment model? And I think many of them are. Aetna, Cigna, many of the Blues plans, the leading accountable care organization model in the country comes out of the Blue Cross Blue Shield plan in Massachusetts. So getting the private payers, perhaps with some pressure from employers, to move forward toward payment reform. Changing the federal government is a little harder. Getting laws passed through this Congress, as you know, is going to be non-trivial, but we do have the Medicare Shared Savings Program, which is in place. 300 plus organizations have got shared savings contracts. Many more, another 400 probably have commercial contracts. So there is movement in this direction. It's going to take the feds to make it easier for people to do it. But there's a skeleton of a bill in Congress now by Peter Welch and Diane Black, a conservative Tennessee Republican nurse and a progressive Vermont Republican Democrat, that's about trying to make the ACO model better. So it's hard work. So if I were in a community, I'd be saying, how can I get everyone in our community to say, this is a direction we need to go? I think, so payment reform is a prerequisite. I think the other thing we need to recognize, and there was a lot of talk in the earlier session about the things that states can do or insurers can do to try to improve people's health, wellness programs and other things. But we know that both health and healthcare are locally produced, right? The reason we exercise is because, people walk more in New York City is you can't drive your car anywhere, and at least you got to walk to the subway. So people get more exercise there. So the physical environment is tremendously influential in producing health. The quality of our schools, whether kids are getting exercise during recess. New Hampshire, just announced its results of its obesity in kids, and I don't know how they did it, but 30% reduction in the last 3 years in childhood obesity.
Don't you think we should know what they did?
I should know, but I haven't had time to look it up.
Isn't that on your Dartmouth Atlas of Healthcare?
No,
you're supposed to be the encyclopedia.
I know I'm supposed to know this stuff. It's just I know less and less every day. because we all have so much to learn. So if we recognize that health and healthcare are locally produced, then you start to say, what do we do as communities to get all of our businesses pushing the providers to get together and say, all right, we're willing to move toward global payment. Yes, it's going to be uncomfortable. And we're going to work with our insurers and employers in this community to push toward global payment models.
I think, Louisianans have the opportunity to move forward rapidly toward the kinds of new payment models that people really believe are critical to changing our healthcare system, and toward the community-based population health improvements that we've heard about this morning, that Blue Cross and others are, and many of the employers are pushing forward on.
I think you have people here that are all key stakeholders in the Louisiana healthcare system who collectively say we're not getting the healthcare outcomes here that we should, and looking at avant-garde in different ways to try to up the amp out there. And you've got the Ochsner health system, you've got Blue Cross Blue Shield, you've got people, you've got doctors and providers and insurers across the spectrum and saying that it's just not working. But you've got experiments that are having dramatic results in this state on things like chronic diseases and obesity and diabetes and others in terms of getting greater compliance from patients. And so I think that what we saw here was a potential turning point in the consciousness of the state, key stakeholders in the state, in organizing and collaborating in very different ways to change what has been a fairly dismal outcome for the state, which a lot of money is spent but not a lot of health achieved, into something where those are turned around, where there's less money spent perhaps, but much greater health care outcomes achieved.
Well, this is such an important issue and such an important matter, healthcare. People always are concerned about their health. We've got to do a better job in the healthcare system making it affordable, and I'm really looking forward to getting the message out there today.
Change is possible. Change is happening. It's time for us to get going and help it happen.
I think I was impressed with the candor and the honesty of people. You didn't find people here that simply were taking the 2 or 3 things they most thought were in their economic interest and just saying them louder. I think you saw real inquiry, self-reflection, self-critique, and earnest thinking about how things might be different in the road. That was consistent throughout today's program. But we had a spokesperson for a national program, A Million Hearts. Then we had practitioners here in Louisiana, and then we had somebody from Dartmouth who has basically created a map of trends around the United States. What communities that may not have a lot of resources are just outperforming and hitting above their weight? What are they doing that's replicable and copyable elsewhere? And I think that mix of perspectives creates an honesty and candor about what might be possible, and so that was all very impressive to me.
I'm excited to be able to report today that after a year we've actually seen very substantial improvements in all of the quality metrics that we've been monitoring within the program. Our program focuses today on diabetes, hypertension care, chronic kidney disease care, and vascular disease care, and there have been substantial double-digit percentage increase improvements across the board in just year one.
You would think for the amount of money that we're spending we're getting excellent outcomes, but unfortunately here in Louisiana we always rank toward the bottom. So we bounce around between 49th and 50th in terms of health outcomes, which equates to the health of the population in Louisiana.
This has been the Louisiana Hometown Network. If you have questions about this program, call us at Hometown Productions.